Diffuse axonal injury, DAI, is a type of traumatic brain injury that occurs when the brain rapidly shifts inside the skull due to rotational or acceleration deceleration forces, causing axons, nerve fibers, to stretch, tear, or disrupt. DAIs are typically widespread, affecting multiple areas of the brain, and they are one of the most severe forms of brain injury. Here is a detailed explanation of the types of diffuse axonal injuries. 1. Classification based on severity. DAI is categorized into three grades based on the extent of damage and the regions affected. Grade 1, mild DA, involvement. Microscopic changes are observed in the white matter, particularly in areas like the corpus callosum and subcortical regions. Pathology. Axonal swelling and disconnection occur, but the damage is often less extensive and may not be visible on standard imaging techniques. Clinical manifestations. Symptoms include temporary loss of consciousness, headaches, dizziness, and cognitive impairments. Recovery is more likely compared to severe forms. Grade 2, moderate DAI. Involvement. Axonal damage extends beyond the white matter to include the corpus callosum. Pathology. There is visible evidence of axonal retraction balls, swelling of the severed axons, and hemorrhagic lesions in the corpus callosum. Clinical manifestations. Longer periods of unconsciousness, significant cognitive and physical impairments, and possible post-traumatic amnesia. Grade 3, severe DAI, involvement. Axonal damage affects the brainstem in addition to the corpus callosum and other white matter areas. Pathology, extensive axonal disruption, hemorrhages in the corpus callosum and brainstem, and widespread neuronal damage. Clinical manifestations, prolonged coma, severe neurological deficits, poor prognosis, and often vegetative states. 2. Classification based on anatomical location. DI can also be described based on the brain regions involved. A. White matter lesions. Damage primarily occurs in the subcortical white matter, particularly in the frontal and temporal lobes, common in cases of mild to moderate trauma. B. Corpus callosum lesions. Axonal injury in the corpus callosum, a critical structure for interhemispheric communication. Common in moderate and severe DIs, often associated with hemorrhages. C. Brainstem lesions. Involvement of the brainstem is characteristic of severe DAI. The brainstem's role in regulating consciousness and vital functions contributes to the high morbidity and mortality rates. 3. Classification based on imaging characteristics. Imaging techniques, particularly MRI, are crucial in identifying DAI. The classification is sometimes based on findings. Schacht A, non-hemorrhagic DI, characterized by subtle changes such as microstructural axonal damage, often detected through advanced imaging modalities like diffusion tensor imaging, DTI. B, hemorrhagic DI, associated with small pinpoint hemorrhages visible on T2-weighted MRI or gradient echo imaging, indicates more severe damage, often involving the corpus callosum and brainstem. Classification based on temporal evolution. DI can also be categorized based on the progression of injury. AA, acute DA, occurs immediately following the traumatic event. Initial axonal stretching and disruption dominate this phase. B, chronic DA, reflects long-term changes including axonal degeneration, gliosis, and atrophy, often correlates with persistent neurological and cognitive deficits. HAR5, pathophysiological classification, based on the underlying mechanism of injury. A, primary axotomy, immediate physical disruption of axons due to mechanical forces, typically occurs at the moment of injury. B, secondary axonal injury, progressive axonal degeneration triggered by metabolic and biochemical changes, including calcium influx, mitochondrial dysfunction, and inflammatory responses, develops hours to days after the trauma. Key factors influencing DAI outcomes. Severity. More severe injuries result in worse outcomes. Location. Brainstem involvement indicates a poor prognosis. Age. Younger individuals may have better recovery potential. Comorbid conditions. Pre-existing neurological or systemic conditions can complicate recovery. Prognosis. Mild DA, good recovery is possible, although long-term cognitive issues may persist. Moderate to severe DI. Prognosis is variable, with a high risk of long-term disability or death. Early diagnosis and management are critical in mitigating the effects of DAI and improving outcomes. Advances in imaging and neuroprotective therapies continue to enhance the understanding and treatment of this condition.